I understand that one of the key points is the selection of the right patient for this procedure. Dr. Mullol, in your opinion, what is the right patient for this treatment?
Well, this is very difficult. I think the three words that were stated: convenience, not only for the doctor, but also for the patients, and also for the social system to avoid waiting lists and so on, is one point. Efficacy is also a very important word on that, and it's not the same as you stated, a reoperated person or patient, or a patient that you are going to do a polypectomy alone, and if it's old or young, or on those patients that you are going to conduct an extension or an important sinonasal surgery, endoscopic sinonasal surgery. And finally, risks. Also, it comes very close together with the efficacy. I mean, if you do a single polypectomy in a person that has cardiac problems and has 75 years old because he has a very obstructed nose, and you decide to do in those patients only a single polypectomy because the main problem is obstruction, so on, the risk is quite very low with the microdebrider. The bleeding is also very low. But if you want to conduct in an asthmatic patient or an aspirin intolerant patient, a wider disease, with the risk of cutting a venous or artery, a small artery, and you have an important bleeding, then you cannot do that in this CMA, what we call it CMA, that is ambulatory major surgery that we use. The other important issue is you defined this kind of surgery only local.
So
local.
I think
in our hospital, for example, is defined also under sedation. I mean, this kind of surgeries can be done under sedation, very soft. There is an anesthetist, but the sedation is much short in the time on the effects. It's for half an hour, 40 minutes, and so on. That in some cases also is much better than the local in our hands, in our indication. That to select the patient, I think, depends very much in these three issues, but also in the kind of surgery that we are talking about. What we are going to do, what we want to do.
Dr. Leunig, according to you, for who is this a promising procedure?
I think the indications are manifold. It depends first, the selection of the patient depends first of all on the patient itself, the pathology, what he's presenting. If the patient is willing to do it, to let it be done in local anesthesia, and of course of the surgeon, he should be trained, experienced, and having the technology. And maybe in some patients who are having risk factors, a local anesthesia would be much safer for the patient instead of doing a general anesthesia. So even in these patients would be an indication, but you have to select it very carefully, maybe with the anesthesiologist and the surgeon together, and then you have a wide field of indications. But it's not just this indication or that, it depends on different factors you have to consider.
Dr. Prokopakis?
I have done a big number of operations under local anesthesia. As Joaquim stated before, in our department we always use sedation prior to the procedure, and then we apply the local anesthesia. I believe that there is a need of proper selection of patients to be undertaken local anesthesia. Patients with no comorbidities, no hypertension, no high-risk patients. On the other hand, sometimes there are patients that anesthesiologists require from us to perhaps apply local anesthesia instead of general anesthesia in those individuals. So I think that in the hands of a well-trained surgeon, local anesthesia is an alternative that offers a safe mode to perform any procedure. I do not use, I always use 4.0 scope. Very rarely there is a need for us to use a 2.7. And the instruments most of the times are the same in our hands that we use under general anesthesia. And talking about what kind of procedures, of course, septoplasty is one of the procedures that you can easily do under local anesthesia in selected cases. Of course, if you see a patient that he is negative or he is very anxious, then you won't do it. But even functional endoscopic sinus surgery, if there is a limited, if there are no involvement of a sphenoid sinus or frontal sinuses, I think that you can easily perform those limited, interventions. There are other procedures like reduction of the inferior turbinates that we do under local anesthesia with radio frequencies, even though we perform all septoplasties with a combination of the reduction of the inferior turbinates. In cases of dacryocyst or rhinostomy, there are cases that we can very easily do under local anesthesia, even though personally I prefer those cases to perform under general anesthesia. And yes, I think that this is a very nice alternative. And in the past, we have measured the intraoperative time, from case to case. And in our setting, it was approximately 40 minutes for general anesthesia cases, while it was half time, 20 minutes for local anesthesia cases.
But let's stick to patient selection at this point in time. Dr. Hopkins, how would you select the right patient for these kinds of procedures?
So I think it has to be driven by patient choice, provided you don't compromise your surgical plan. So I will consider the patient, their pathology, the extent of their disease, and I will explain to them what I think is the best evidence-based procedure for them. And if that involves an extensive procedure, and if I had to compromise on that to perform the surgery under local, I don't think they'd be a good candidate. If I think that they've got fairly limited surgery that I could achieve I think there's a time duration element to it. I think there's probably a limit of about 30 minutes beyond which patients don't tolerate this very well. So if I think I can achieve the complete procedure with good pain control in under 30 minutes, I would offer the patient the choice. And then it's really down to them as to which they would prefer. And as we've heard, some patients would much rather be asleep under general anaesthetic, and that's absolutely fine. And some patients would prefer to avoid the risk of an anaesthetic and the recovery that comes with it. So I think provided those first conditions are met, I'd leave it to the patient.
Do we need more real-life evidence for this relatively new practice?
I think we need to have clear documentation of what we're doing and build up case series indeed, because I think there's important outcomes that need to be assessed from this in terms of general patient experience, but also the patient's nasal outcomes in terms of improved symptoms. But there's also the health economic side of it that needs to be looked at, because inevitably when one starts this, you begin to look at the remuneration, and so building up evidence to inform that is important.
Mm-hmm. Dr. Constantinidis, what are your feelings about this?
We do it in my department every week, one day. We have I would like to focus in the personality of the patient, because I think this is a procedure that needs an excellent collaboration between the surgeon and between the patient. Of course, if we see that there is a patient with comorbidities, cardiopulmonary diseases, or if the patient had a deep vein thrombosis, or if he is anticoagulated, this is for us not a candidate to do it in local anesthesia. And the second most important thing is the safety. I think and I believe we have to do these procedures only in a place in the hospital that we can switch to general anesthesia if it's necessary first, or if we can quickly save our patients. For example, if our patient has vagovagal reflexes, or if he has problems, because we saw in a long time experience that they are really healthy patients with no comorbidities, with nothing. They had problems. So we have to think as doctors also about safety. This is very important. And one anesthetist should be standby if we need something. So it must be well organized, and it must be in the hands of an experienced surgeon, the selection of our patients, and also we cannot send our young residents to perform local anesthesia the first operation, you know. And the duration, the other thing what we have saw is the duration of the surgery is also important. If it's only a polypectomy, it's not a problem. But in my experience, if we are more than 45 minutes, 1 hour, this is not, the patient is not collaborative enough. So we have to think also about the duration of the surgery.
Dr. Hopkins?
I think you're absolutely right. This has to be about improving the patient experience and not driven by saving money. And I think inevitably it will be more cost effective. But if that takes over, we run the risk of ignoring patient choice and being sent out to a broom cupboard at the back of the hospital in an isolated environment to do these in an office environment. And it has to be done with the same respect to safety and resources that we would any other procedure.
Dr. Noble, what are the key success factors according to you?
The key success. I'm going to start with the history to answer to your question. 25 years ago, when I started as a fellow, when we performed a septoplasty in the university where I work, the patients came the day before the surgery, just to check if everything is okay. And then the surgery came, and then the patient received a 4 days packing in the nose. And then we remove the nasal packing and wait 1 night to see if everything is okay. And so the patient can discharge from the hospital the day after. So it means that for usual septoplasty, the patients remain 7 days in the hospital. That was 25 years ago. No, it's not possible to continue like this, and the economy of health told us to change our practical and our way to do the surgery. Now we move completely in another way. Now we are performing for nasal surgery in the department. 5 years ago, it was 45% of the procedure. And we try to increase the number every year, and now we are approximately at 55% of the cases. I'm not speaking about local versus general anesthesia. It's an ambulatory process. For me, the key success, as the question was that, for sure you need to exclude many patients. And as someone said, patients with problem with coagulopathy, hemostasis, old patient, it's not possible to do that in an ambulatory process. Also, there are specific cases, specific indications of the surgery where for me it's not possible to do that in on 1 day surgery. Draft 3 procedure, malignancy, etc. It's not possible for me to do that on 1 day surgery. But if you are well prepared, if the nurses are okay, if the operating room are okay, you can do a lot of surgery on 1 day surgery. You need to be very prepared and also very well organized, because the patients will come at the clinic very early, and from this point, when they came into the clinic, the time is running, because you know that 5-6 hours after, the patients need to be discharged. So it's really important to be very well organized and very quick in the procedure.
Dr. Carrie?
So I think, listening to the panel, clearly there are very different models of what is ambulatory surgery, from what essentially sounds like day case surgery under general anaesthetic, through surgery with sedation, through to surgery without sedation in a clinic setting. And all of those models are correct for that particular environment.